Hello everyone, my name is Kyle Burkett, and today I'm going to be talking to you about a journal article that I'm reading for a Grand Rounds presentation. The article was published in the Journal of Trauma and is called Scoop and Run to the Trauma Center or Stay and Play at the Local Hospital, Hospitals Transfers Effect on Mortality by Nirula et al. So this is a pretty common problem that we have in the emergency department, and it's the topic of much debate, and that is, what should the pre-hospital system really resemble? Should it represent a system that offers a high level of care and therefore sort of takes longer, so EMS personnel having advanced skills, versus probably what days gone by were more like, where EMS personnel more so scooped up patients from the road or from wherever they were and brought them sort of directly to the hospital with a maybe possible decrease in transport times, but definitely a less high level of care while being transferred. This article itself starts off, as most articles do, establishing some clinical equipoise, and they do that quite well. They quote some other articles stating that it's been, when you look at all traumas in the National American Trauma Database, that mortality was about 20% greater in non-trauma centers than in trauma centers. So if you had a major, and that is major defined by ISS score, trauma happen to you, if that trauma happened to you right outside the level 1 trauma center, versus if that same trauma happened to you outside of a non-trauma center, you had a 20% chance better survival rate in the trauma center. They also quote some other really interesting papers talking about motor vehicle collisions and the mortality associated with those. And when there's regionalization of a trauma system, so a regionalized trauma system, RTS, the mortality of MVCs goes down. So this is if we can move people from their motor vehicle crashes that are far away from a trauma center, if we have a way of bringing them to a trauma center, that seems to improve mortality. They also sort of play on this stay and play versus grab and run mentality by saying that there's definitely some proof that some interventions in the field actually improve mortality, specifically intubation and IVs probably have some evidence behind them. But that when there was a recent meta-analysis done that looked at all comers for trauma, and if you received basic life support versus advanced life support, mortality was actually increased threefold in the advanced life support group. So there might be something about trauma. What they're trying to say is there might be something about trauma that's different than other medical conditions. So if EMS personnel can get to you and they can give you IM epinephrine during your anaphylaxis, that is life-saving and that is completely reasonable to give in the field, and it makes sense that we would do that. I think a little bit more equipoise lives on in the trauma world, and so this article tries to tackle that. Their question specifically is looking at transfer from the field to a non-trauma center to a trauma center, and is that better or worse than field transfer directly to the trauma center, even if the transport time is longer? So if I get hurt out in rural Alberta and I have to fly over one peripheral small hospital in order to make my way to the larger trauma center, is my mortality better if I do that, or is it better if I stop off at the small peripheral hospital and wait there, get some treatment, and then I'm transferred from there after some stabilization to the level 1 trauma center? And of course, I want to repeat that they specifically mean at non-trauma center. So stabilization, definitely possible. Definitive surgical care, definitely not. So that would be the thing that separates the trauma center from the non-trauma center. In general, they looked at a fairly large database that was being used for another study, so they kind of just piggybacked on. They used the Blue Grant Trauma Database, which is one of the US, and they looked at major blunt trauma occurring between 2004 and 2007. And what they did is they examined about a little over 1,000 people, the majority of which, 71%, were transferred directly to the trauma center. So only about 30% going to a non-trauma center and then being transferred on. And they basically looked at, they did a regression analysis to look at a ton of different factors. And the two places that they really tried to focus, because that's where their statistically significant differences were in hypotension, base deficit, and associated base deficit, and also in mortality. So what they found interestingly is that the patients who showed up to the trauma center directly from the field, as opposed to from the non-trauma center, had worse hypotension, which I think makes sense. You go to a non-trauma center, you get some fluids, maybe some blood, etc. Then you're transferred, so you're not transferred in an unstable way. That's good. But what they found is that we know base deficit is associated with poor outcomes, and what they found is that the patients who were transferred from the non-trauma center, it took a lot longer for those patients to clear their base deficit. And they wondered a lot about this, and they wondered if it was potentially because of the judicious use of IV crystalloid, which was prevalent in those transfers, as we would expect it to be. But they also wondered if maybe there's something about definitive care early on that allows the base deficit to be cleared more quickly. And I think they're trying to touch here on something called damage control resuscitation, which is gaining a lot of traction in the literature right now. And I suspect that there's something to be said for that, but they can't actually prove that with this study. So they basically just comment on hypotension, base deficit, and mortality. So in terms of mortality, through their logarithmic regression analysis, they found that if you went from if you were transferred from the field to a non-trauma center, and then to a trauma center, you had a 3-fold increase in mortality, and that was significant, as compared to people who were transferred directly from the field to the trauma center. So very interesting results. They try to explain this. Obviously they can't explain what sort of factors physiologically led to this increase in mortality in people who were transferred from the non-trauma center to the trauma center, but they try to explain it with the hypotension, the base deficit, and looking at how long that base deficit takes to clear. But again, they're not sure, and they don't know what the exact reason of that was. For you visual learners, here are the results in a table. So in general, you notice that the 95% confidence intervals don't cross 1 outside of a few places. And one of which was here. I'll draw your attention to transfer. So this was model 1. This was the pure regression analysis. Model 2 was a more complicated model where they controlled for some other statistics and tried to remove people specifically who died within 24 hours. So the thought being there that if you pass away within 24 hours, they didn't want to bias the study by having the super sick people there, and part of that was that more of those people got transferred directly to a trauma center, or sorry, directly to a non-trauma center, because they were so acutely unwell and on death's door that the personnel transporting them just stopped at the closest site as per their protocol. And so here's where that 3-fold mortality comes from. And then if you take away those other factors, the mortality was still statistically significant, and it was a 2.8 difference. So basically the discussion was, though these transfers arrive at the trauma center less hypotensive after being at the non-trauma center, their base deficits took much longer to clear. And one of the hypotheses behind this was the less resuscitation theory. So the idea being that you're the doc at the non-trauma center, or sorry, at the trauma center, you receive a patient who's vitally stable, or at least reasonable, from a non-trauma center, and so probably you don't as aggressively treat that patient, even if they haven't gotten things like blood, even if their vital signs have just been normalized with IV crystalloid, and so possibly that's part of what's at play here. And then of course, one of the other thoughts behind this fairly large increase in mortality with transfer was maybe this is the golden hour. So maybe what happens is people who come into the trauma centers directly from the field are sicker when they come in, as based on their vital signs and general clinical picture, and also by their ISS scores, given that the ISS scores take in vital signs and whatnot into factor. But somehow definitive care may be at play here. So they come in sicker, yet they die less frequently. And so probably the golden hour is what's at play, and the golden hour to do something useful is what changes outcomes. And that's the author's hypothesis, though they can't prove it, of course. Anyways, so that was a quick review of that article, and maybe you can all come to my grand rounds in Winnipeg on December the 15th. Talk to you later. Bye.